Good evening, everybody. Welcome to this another session of online echocardiography, 46th comprehensive course on echocardiography from Giraffe Institute. Today we have with us none other than Dr. Debika Chatterjee. She is an in-charge echocardiographic lab or a non-invasive cardiac lab at Narayan Hridayalaya RNTI Hospital at Kolkata. It's always feel pleasure and proud to say that Debika at one time was student with us, and now she has grown so much that she has become a legend by herself. And always gives us so much happiness that when the people we have trained and they become legends, we always feel happy about them. She's one of them. And with this few words, I like Debika to take over and start her deliberation on diastolic function by echocardiography. Dr. Debika, it's all yours.
Thank you, sir, for the kind introduction. And hello, the delegates. Though I can't see you, but since I think this is a fresh batch, and I welcome you all to our echo learning sessions. I'm going to talk on the assessment of diastolic function by echocardiography. Let me start my presentation with a patient who is 60 years old, obese male with history of hypertension, complaining of progressive exertional dyspnea with fatigue, and on examination you get bilateral ankle edema, hepatomegaly, and bilateral crepitations. So the diagnosis obviously is congestive heart failure. Now the question is, what is the cause of this heart failure? As usual, we always think, is it due to systolic dysfunction? So we look at the heart. You see, in the parasternal long axis, LV is showing good contraction, no regional wall motion abnormality. Overall systolic function is very good with an ejection fraction of 65%. Then I do the Doppler echocardiography. I rule out any left to right shunt. I rule out right heart pathology. And then I find that this particular patient has got diastolic dysfunction with elevated LV filling pressure. So this particular patient is in diastolic heart failure with preserved ejection fraction, an entity known as HEPF, and it accounts for around 50% of all heart failure, responsible for significant morbidity, mortality, and recurrent hospitalization, and prognosis is as bad as systolic heart failure. So we need to know how we can identify the diastolic dysfunction by echocardiography. You see, the diastolic dysfunction and diastolic heart failure is different. Diastolic heart failure comprises of, it's a syndrome, it comprises of shortness of breath, swelling of the legs, crepitation, etc. And diastolic dysfunction, all the patients having diastolic dysfunction might not go into diastolic heart failure. But we must know how to decipher the diastolic dysfunction in a patient. Now, when we do echo in a patient with heart failure, we always try to get the answer of few questions. Like, is this patient truly have the HEPF, or his or her shortness of breath is due to some other cardiac or non-cardiac cause? We also want to know how how our therapy, unloading therapy is doing its function, so that we can optimize it. And also we need to estimate the prognosis and follow up our treatment. Now the answer of all these questions can be obtained by assessment of diastolic function by echocardiography, because echocardiography gives us idea about not only about the structural problems of the heart which give rise to the diastolic dysfunction, but it also gives us very good idea about the functional problem, specifically the LV filling pressure, because it is the elevated LV filling pressure which is the final component, final common effect of diastolic dysfunction. And it is the elevated LV filling pressure which results in shortness of breath in HEPA. And moreover, it is a marker of poor prognosis. So we have to know the LV filling pressure. And not only that, if you see the latest recommendation of American Society of Echocardiography for assessment of LV diastolic function, the grading of diastolic dysfunction is based on the presence and or absence of elevated LV filling pressure. So our diastology echo report should contain not only about the a line about the presence of diastolic dysfunction, we should also make a comment on the status of LV filling pressure, whether it's normal or elevated, because that's the way we grade the diastolic dysfunction. Now let us recapitulate a bit of physiology of diastole of the heart. As you know, it is the phase of filling of the ventricle. It starts with aortic valve closure and ends with mitral valve closure. And it is the process by which heart returns to its relaxed state. And if we look at the phases of diastole, it starts with isovolumic relaxation phase. So aortic valve closes and myocardium, LV myocardium undergoes relaxation. And it is because of the elastic recoil and also the removal of calcium ion from the sarcomeres. So as a result of that, the myocardial relaxation, the LV pressure falls. And a time comes when the LV pressure is below the LA pressure and the mitral valve opens. So if the mitral valve opens, the blood will flow from the LA to LV. So a gush of blood comes from LA to LV. Around 80% of the filling of left ventricle takes place during this early rapid filling phase. As soon as the mitral valve opens, early rapid filling starts. And that gives rise to the E wave. Look at the LV pressure curve. This is the rapid filling, early rapid filling. Now, as the LV gets filled with the blood, LV pressure again rises. And what happens? A time comes when there is equalization of pressure of LV and LA. There is no more, the positive pressure difference between LA and LV. So blood decelerates. Blood decelerates, and we get the deceleration time, and we get the diastasis. And that 20% of the blood is still into the left atrium. So the atrium undergoes contraction. We call it LA pump or late diastolic filling phase, by which the 20% of the blood from the left atrium goes to the left ventricle, which gives rise to the A wave. So normally E is more than A wave. And you must have seen the two factors are strongly associated with the normal diastole. One is the relaxation of the myocardium. There is the ability of the myocardium to relax during diastole, and a compliance. LV has to undergo this, it is a distensibility. LV must be compliant to receive the blood from the left atrium. So distensibility of the relaxed ventricle, that is the change in volume in change of pressure, should be normal. If both these factors are normal, then we get Normal diastole, where there is adequate LV filling without increased LV filling pressure at rest as well as with exercise. But if there is delayed relaxation or reduced compliance of the LV due to stiffness or due to various diseases, long-standing hypertension, ischemia, cardiomyopathy, there will be impairment of the LV filling in diastole. That will result in increased filling pressure for a given volume, and in return, it will increase the LV pressure with enlargement of the left atrium. It will increase the pulmonary venous hypertension, and patient goes into diastolic heart failure. So this is the pathophysiology of diastolic heart failure. Now, if we look at the causes of diastolic dysfunction, you see the old age is at the top of the list. Because as we know, the aging results in changes, some changes in the heart and the vascular system. What happens? The relaxation becomes impaired, normal impairment. It's due to the aging process. So that impaired relaxation in an old patient who is more than 60 is normal, but that would be abnormal in a young patient who is below 60. So age is a factor which we must remember while assessing the diastolic dysfunction. Long-standing hypertension is one of the causes. And then the cardiomyopathy, different types of cardiomyopathy, hypertrophic, restrictive, which might be infiltrative, which may be non-infiltrative. The cardiomyopathy of any type, the myocardium cannot relax. So we get diastolic dysfunction. Coronary artery disease, it results in ischemia of the myocardium or infarction. So ischemic myocardium and infarcted myocardium cannot relax. So we get diastolic dysfunction. Then comes the constrictive pericarditis. It is an extrinsic cause. Because of the rigid pericardium, the diastolic filling is hampered in constrictive pericarditis. So resulting in diastolic dysfunction and obesity and sleep apnea. Now, if we start looking at the heart for assessment of the diastolic dysfunction, we always start with two-dimensional echo. And we get certain objective evidence of cardiac structural problem, which will give you a suspicion of presence of diastolic dysfunction. Like this is a case of hypertrophic cardiomyopathy. Look at the septum, how hypertrophied it is. So an LA is enlarged. So you start thinking that this patient will have some diastolic dysfunction. So also in this case, there is a large infarction in the LAD territory. So this patient also will have a diastolic dysfunction. As I said, this myocardium cannot relax. But the most important two-dimensional echo parameter, which we should look for while assessing the diastolic dysfunction, is an enlarged LA. It is a robust indicator of diastolic dysfunction with elevated LV filling pressure, and of course, in absence of anemia, atrial fibrillation, mitral valve disease, where even in absence of diastolic dysfunction, we'll get enlargement of LA. Now, the question is, how do we measure left atrium? For decades, traditionally, we measure the left atrium in the parasternal long axis, where we can measure the anteroposterior dimension of the left atrium. That we measure in end-systole. Anterior point is taken at the level of the midpoint of sinus of valsalva of aorta, and the posterior point is taken in such a way that this line remains perpendicular to the long axis of the left atrium. And that way we get a diameter. The upper limit of normal in adult is 4 centimeter, or you can index also. Now, though we measure it, but as per the latest American Society of Echocardiographic recommendation, we cannot use this anteroposterior linear dimension as the sole measure of LA size. Why? The answer is very, very simple. If you look at the left atrium in this model of the heart, you look at the left atrium, it is an asymmetrical three-dimensional cavity. It does not enlarge consistently in all directions. It may so happen that you are getting a normal anteroposterior diameter but the LA is actually enlarging in its medial to lateral direction or superior to inferior direction. Moreover, LA expansion in anteroposterior dimension may be constrained by the thoracic cavity between sternum in the front and spine at the back. So LA volume should be measured along with the anteroposterior dimension, linear dimension of left atrium. Moreover, the medical literatures have shown that LA volume index is a more robust cardiovascular risk marker than the linear diameter to reflect the burden and chronicity of elevated LV filling pressure. And it is a strong predictor of outcome in diastolic heart failure. So it is the indexed LA volume which should be a routine lab measure in your echo lab. How do we do it? We do it from two apical orthogonal views. We call it biplane method. Which are those two apical orthogonal views? One is apical 4-chamber, another is apical 2-chamber view. We measure the volume at ventricular end systole. That means LA is in its maximum volume during the ventricular end systole. Mitral valve is still closed. We use either area length method or disc summation method, which we call modified biplane. This summation is the one which divides the LA into multiple discs and then calculate the volume. Out of these two, the disc summation method is the one which is preferred. Now let us see how do we measure it. So first we go to the apical 4-chamber view, and then we freeze the image and choose the LV end systolic frame. LV end systolic means LA in its maximum volume. So we start tracing the LA endocardial margin from one annulus, say septal annulus, and go round and round and round, excluding the LA appendage. We don't go inside the LA appendage. We don't go we don't go into the pulmonary vein. We don't go into the LA appendage if it is opened. And also we don't go below the mitral valve area, the tenting area. We start from one annulus and end at the other annulus. And the machine joins these 2 points with a line, which is called interannular line. And then we take a length. The length is taken from the midpoint of the interannular line to the midpoint of the superior wall of the left atrium. And it should be absolutely perpendicular to the interannular line. And we repeat this procedure in the apical 2-chamber view. This is 4-chamber view and this is 2-chamber view. Then the machine calculates automatically. We give the values, area 1, area 2, and out of these two lengths, machine will take the shorter value and utilize this formula of 0.85 multiplied by area 1 multiplied by area 2 divided by shorter length. We should be careful that this length of apical 4 chamber and apical 2 chamber should not differ more than 10%. If it is more than 10%, you repeat the procedure once again. So that way you get a value, and then you divide it with body surface area, you get indexed LA volume. And as per the AEC guidelines, the upper limit of normal is 34 ml per square meter body surface area. Now, look at this patient. Look at the left atrium in the anteroposterior diameter. The measurement is 3.61 centimeter. But if we look from the 4th chamber, it definitely looks bigger. So look at the LA volume index. I measure in the apical 4th chamber and apical 2 chamber by modified by this summation method, and I get a value of 35.3 ml per square meter body surface area. See, so what it has shown, that anteroposterior diameter is normal, but LA is actually enlarged because the enlargement has taken place in another plane, either the medial lateral or the superior inferior. So while measuring the volume, you get everything in your calculation, so it gives the accurate figure. So LA is definitely enlarged in this patient. Now there is a caveat while measuring the LA volume by disc summation method. Look at this picture. See, I have told this length should be perpendicular to the interannular line. But this particular patient, where I have measured this length is not perpendicular. This is not 90 degree, this is less than 90 degree, and this is more than 90 degree. So what is happening? Look at these two areas with red star. This is a dead space at the top. Again, at the bottom, there is another dead space. These two spaces are not in the calculation. So obviously, you will get a wrong value. Actually, it should be like this. This length should be perpendicular to the interannular line. So these you can avoid by avoiding foreshortening of the left atrium. Get a proper left atrium without foreshortening. So you should not take this type of measurement for the LA volume. You should go for this one, where the length is perpendicular to the interannular line. Next, after the two-dimensional echo parameters, we will move to the Doppler pattern for assessment of diastolic dysfunction, where at first we measure the mitral inflow Doppler. We look at the Doppler pattern. As I have described you, normally the E wave, which is due to early rapid filling phase, is bigger than the A wave. Now, as the diastolic dysfunction sets in with impaired relaxation, E wave becomes small. So obviously the rest of the blood has to go to the left ventricle by atrial pump, and that results in a higher velocity of the A wave. So E becomes less than A wave. But as the diastolic dysfunction advances from this stage, the LA pressure starts rising. So when the LA pressure is moderately increased, LV and diastolic pressure also is increased, obviously. So that time what happens? Again, the A wave becomes smaller than the E wave. Though the impaired relaxation pattern is masked here because of the raised LA pressure, we must remember it. Here the E wave is more than the A wave. Now, as the diastolic dysfunction, we call it pseudonormal pattern. And as it advances further, the A wave becomes smaller and smaller, E wave becomes very big because LV has become non-compliant and LA pressure is significantly high. So that is why we get a pattern of tall E, short deceleration time, and a short A wave. So we must remember that relaxation abnormality present in all grades, starting from here, here also, here also. It is the raised LA pressure which has masked the impaired relaxation pattern, resulting in A wave less than the E wave. Now, if you look at these two, this pattern where E wave is more than A and the normal pattern E is more than A, they look very similar. So how to differentiate these two patterns? Look here, this is a patient who has come for a normal heart checkup, and we get E wave more than A wave. Whereas you look at this patient, this is a patient of hypertrophic cardiomyopathy, as you can see. Look at the LA, hugely enlarged, and you get again E wave more than A wave. Now we know that this is abnormal, and this might be normal, but then how do we differentiate? How do we confirmly tell that this is normal, this is abnormal, this is pseudo-normal? So there are two methods to differentiate. One is the Valsalva maneuver, where we ask the patient to do the forced expiration with closed mouth and nose. That reduces the preload, and that impaired relaxation pattern is unmasked. And another is tissue Doppler imaging of the mitral annulus. So first, let us see what happens with the Valsalva maneuver normally. Look at that patient where we got E wave more than A wave, and we didn't know whether it's normal. So we asked the patient to do the Valsalva. Look at the flow pattern. This is the one normally, and here he has started doing Valsalva. Look at E and A. The velocity of both E and A are going down and down proportionately. E also less, A also less. So EA ratio remains normal. So this is a normal filling pattern. On the other hand, if I look at the that case of hypertrophic cardiomyopathy, where I got E wave more than A wave, and I asked the patient to do the Valsalva, look how it has gone back to its impaired relaxation pattern. And again, E wave becomes smaller than the A wave. So this particular pattern is pseudo-normal. So this is one of the ways to differentiate normal from pseudo-normal. And another is by looking at the mitral annular velocity by tissue Doppler imaging. By this time, you must have learned what is tissue Doppler imaging. There is an option in the machine. So you touch that button, you get this pattern where it colorizes the tissues of the heart. And if you look here, see, this is the mitral valve, this is septal annulus, and this is the lateral annulus. So we will basically measure the velocity of the septal annulus and the lateral annulus. So before placing the sample volume over the annulus, we reduce the sector to increase the frame rate. We need a very high frame rate while doing tissue Doppler imaging. Normally, septal annular velocity is less than the lateral annular velocity. If septum is normally it's 10 centimeter per second, and lateral is 12 centimeter per second. Now let us see what happens in a person who has a normal pattern. Look, in the mitral inflow velocity, E was more than A. So also E prime bigger than the A prime. So this is the baseline. As we are doing the tissue Doppler velocity, what happens? The annulus moves towards the apex during systole. If you look at this image, see, it moves towards the apex during systole. So the systolic wave will be above the baseline, and during diastole, it moves away from the apex. So it will be below the baseline. So during diastole, below the baseline, we get two waves. The first bigger wave in this normal pattern is called E prime, and the second wave is A prime. So in a normal patient, both septal and the lateral annular velocities will show E prime more than A prime. On the other hand, let us see in that pseudonormal, in that patient of hypertrophic cardiomyopathy, where we got E wave more than A wave. And we do the tissue Doppler in the septal annulus. Look, E prime is less than the A prime. So the annular velocity will never let you down. It will give you the exact picture. The less filling is taking place during the early rapid filling phase as diastolic dysfunction sets in. So E prime is less than the A prime. Without any maneuver, using the tissue Doppler imaging, you can get this exact picture in the septal annulus as well as in the lateral annulus. Look, E prime is less than the A prime. Now, when I tell about the tissue Doppler imaging, I must mention about a ratio which is called E by E prime. This particular ratio can predict the LV filling pressure. How? You see, here is the E wave of that patient. E wave velocity is 0.99 meter per second. And septal E prime is 0.04 meter per second. So septal E by E prime, machine gives all these values. You have to only place the caliper. E by E prime is 24.75 at the septal annulus. I repeat the same on the lateral annulus. I get E by E prime 15.5. Now I do the average of E by E prime at the septal and at the lateral annulus. I get a value which is 20.12. As per the American Society of Echocardiography guidelines, if this particular figure or average E by E prime more than or equal to 14, it predicts the raised LV filling pressure. That means the patient's LA pressure is already high. So that is the utilization of this E by E prime. Now, look, another parameter. This is a patient of cardiac amyloidosis. We get a whip of tricuspid valve regurgitation, and with the CW Doppler, we get that tear jet, and tear jet velocity is 3.15 meter per second, and tear jet gradient is 39.7 millimeter of mercury. Now, the normal peak tear jet velocity should be lower than or equal to 2.8 meter per second. So this is definitely higher than that, and that indicates the this raised pulmonary arterial systolic pressure from peak tear jet gradient indicates elevated LV filling pressure. If we add RA pressure, say in this particular patient, RA pressure is 5, so 40, almost 40 plus 5, 45 millimeter of mercury is the pulmonary arterial systolic pressure in this patient. So that definitely indicates elevated LV filling pressure. Now, till now, what are the parameters we have seen for assessment of diastolic dysfunction? Let us recapitulate. One is the LA volume index. Next is the velocities of E and A waves, EA ratio. We also looked at septal and lateral E prime velocities. We took E by E prime ratio and also the tricuspid regurgitation jet velocities. Now comes the classification or grading of diastolic dysfunction. So you see, this is the flow chart given by American Society of Echocardiography. You can always go through these in the literature. So look, mitral inflow. First, you look at the extreme left-hand arm, where it is said that if E by A ratio is less than 0.8, plus E wave velocity is less than 50 centimeter per second, you can straight away tell that it is grade 1 diastolic dysfunction having normal elevation. So this particular patient where E wave is 48 centimeter per second, a 60 years male coming for routine checkup, hypertensive for 1 year, non-diabetic. I do the Doppler pattern of mitral inflow where I get E velocity 48 centimeter per second and EA ratio 0.6, say 0.6. So what is the grade of diastolic dysfunction in this particular patient? Only by looking at these two things, I can tell that LV filling pressure is normal or low as per the AAC, latest AAC guideline. This falls in the grade 1 diastolic dysfunction. I also check by looking at the LV volume index. This is only 28 ml per square meter body surface area. And I also look at the tissue Doppler imaging where look at the average E by E prime, it's only 7.4. So by looking at the E and A wave velocities and their ratio, we can grade the diastolic dysfunction. So also at the left extreme right arm, you see, if your E by A ratio is more than 2, you can straight tell that this patient is having raised LA pressure. Of course, the patient should have a myocardial problem either in the form of cardiomyopathy, ischemia, long-standing hypertension. Then only we'll say that this patient is having diastolic dysfunction, because in a normal individual, you may get a young patient having a very good elastic recoil. Normally, you may get EA ratio more than 2, but that particular young man does not have any myocardial problem. So this is the finding of a patient where you are you know that there is some myocardial disease. So that indicates raised LA pressure and grade 3 diastolic dysfunction. As in this case of cardiac amyloidosis, 56 years male, SOB for 6 months, class 2 to 3, bilateral ankle edema, hepatomegaly. Look at the myocardium, thick myocardium, LA enlarged. LA volume index was 40. And then look at the EA ratio. A very tall E and a small or absent A wave. As I said, it is the restrictive pattern. LV is non-compliant. LA pressure is significantly high. So, and as soon as the mitral valve opens, blood enters with very high velocity because LA pressure is very high, giving rise to the tall E. But since the LV is non-compliant, it is like a balloon made of thick rubber. It is non-compliant. It is the response to the volume, change in volume in response to pressure is not normal. Yeah, so quickly it decelerates, and the A wave is very small because though the LA pressure is high, it is unable to push the blood to the non-compliant LV. So we are getting a very high value of EA ratio, and these we call grade 3 diastolic dysfunction. As I have said, this is not applicable in healthy individual with normal LV, normal ejection fraction. Now, if we check whether this assessment is correct by looking at the, as I said, LA volume index is already high, and look at the tissue Doppler velocities, very small E prime, A prime, as well as S prime. And average E by E prime is 44.6. So this patient is having grade 3 diastolic dysfunction. But we are not so lucky to get these two patterns in each and every case. Sometimes we get a pattern like this. Situation 1, E by A less than 0.8 plus E wave more than 50, and or E by A more than 8 but more than 0.8, less than 2. So let us see how the situation 1 looks like. This is the situation 1. E by A is 0.7, so less than 0.8, plus E wave velocity is 99 centimeter per second, so more than 50 centimeter per second. Here we cannot grade the diastolic dysfunction by looking at the EA waves or EA ratio. Here the LV filling pressure is uncertain to comment, and grade of the diastolic dysfunction is uncertain. We need some additional parameters to comment on the LV filling pressure and grade of diastolic dysfunction. And let us see the situation 2. Situation 2, you see, this is a patient where there is infarction of the LAD territory. There is a thrombus, you can see. Look at the EA ratio. It is 1.38. So situation 2, E by A, more than 0.8, but less than 2. So here also the LV filling pressure is uncertain. So also the grade of diastolic dysfunction. Just excuse me for a second. We need the additional parameters to comment on the LV filling pressure in these cases. So what are those additional parameters? 3 parameters, 3 criteria. One is the average E by E prime, which I have already described. It should be more than 14. Then we say it's a positive criteria. TR velocity, I already described. If it is more than, 2.8 meter per second, we say positive criteria. And LA volume index, if more than 34 ml per square meter, which I have already described, is a positive criteria. Now, out of these 3 criteria, if 2 or all 3 are negative, then you can say that this patient is having grade 1 diastolic dysfunction with normal LA pressure. That is why these 3 are or 2 are negative. But if 2 or all 3 are positive, then definitely the LA pressure is raised and we say it's grade 2 diastolic dysfunction. See, this is a patient where E by A was 0.7, UF velocity 73.8 centimeter, and average E by E prime is 20.7. So we are getting 1 criteria, and then we go to the TR velocity. TR velocity is only 1.48 meter per second. So this criteria is absent. Now let us go to see the LA volume index. It is 35 ml per square meter. So 2 criteria are positive. We can say this patient is having grade 2 diastolic dysfunction. And so this patient is having grade 2 diastolic dysfunction. Now, let us, okay. Now, you see, if you look here, if only 2 criteria are available, suppose the patient doesn't have a TR and 2 are negative, you can say it's a grade 1 diastolic dysfunction. If 2 are positive, then you can say grade 2. And if 1 positive and 1 negative, then you cannot determine the LA pressure and diastolic dysfunction grade. However, you can utilize the other methods like pulmonary venous flow pattern. Now, you know that pulmonary veins enter into the left atrium. This is the right upper pulmonary vein. It is in the posterior field, so often it is difficult, but with today's high-end machine, most of the machines can give a good picture of the pulmonary veins, at least of the right upper pulmonary vein, where you place the sample volume deep inside the right upper pulmonary vein and get the pulse wave Doppler. And this is the normal pattern: a systolic wave, a diastolic wave, and a flow reversal. Systolic wave is more than the diastolic wave. Systole is during the ventricular systole, so LA is in a reservoir phase, blood is accumulating, so we get the S wave, blood is entering into the LA. D corresponds to the E wave, where the flow is started. So it is the conduit function of the LA, and the atrial flow reversal corresponds to the A wave, because during this indicates the pump function of the left atrium. When the LA contracts, the most of the blood goes to the LV, but a part also goes back to the pulmonary vein as a backflow. So that gives rise to this AR, or atrial flow reversal. Normally, you see S is more than D, but in a patient having having low ejection fraction, as in this case of a myocardial infarction in the LAD territory, look, S wave is less than the diastolic wave. Systolic wave is less than the diastolic wave. So this indicates that the patient's LV filling pressure is raised. However, as I have said, it is a challenge because often a suboptimal image may not give you a good picture of the pulmonary vein. And most important, that this particular pattern is not applicable for assessment in healthy young individual with normal LVEF. It should be a reduced LV ejection fraction. Now, as when I have described you average E by E prime, see, there is a condition called annular calcification, mitral annular calcification. Calcified annulus cannot show the proper velocities. So in this group of patients where there is mitral annular calcification, E by E prime is the velocity of the annulus, cannot be applied when there is significant calcification in the annulus. So what do we do? There is an article in JACC in 2017 where they have shown that Doppler echocardiography for the estimation of the LV filling pressure in patients with mitral annular calcification by utilizing criteria called isovolumic relaxation time, which I'm going to show you. So as per that paper, if E by A is less than 0.8, you can straight say LV filling pressure is normal. If more than 1.8, LV filling pressure is high. And if it is between 0.8 to 1.8, you should measure the IVRT. If more than 80 millisecond IVRT, normal LV filling pressure. If it is less than 80 millisecond, high LV filling pressure. So this is a paper. This is not yet in the guidelines, but you need to know how we measure the IVRT. That is why I have shown you this paper. So what is that IVRT? IVRT is the isovolumic relaxation time. It is the time between the aortic valve closure to mitral valve opening. As soon as the aortic valve closes, the mitral valve doesn't open because myocardium, LV myocardium has to relax. Its pressure should come down with below the LA pressure. So that time, the aortic valve closure to mitral valve opening time is called the IVRT. A normal value is less than 70 milliseconds. Now, how we measure it? We go to the apical 5-chamber view, where you open the LVOT and get the cursor, place the sample volume between the mitral valve and the LVOT, somewhere here, and get the pulse wave Doppler. As you do so, you will see that above the baseline, you will get the mitral inflow, and below the baseline, you will get the LV outflow. So The LV outflow stops here, so aortic valve closes, and there is a gap before the mitral valve opens. E wave starts here, so this is the time of isovolumic relaxation. So you measure this time. Look here, it is 66.54 milliseconds. As I said, normally it is less than 70 milliseconds. And it is inversely related to the LV filling pressure in diastolic dysfunction. It gets prolonged with normal LV filling pressure, and it shortens with raised LV filling pressure. An IVRT less than 65 millisecond indicates raised LV filling pressure in atrial fibrillation. Because in atrial fibrillation, we cannot measure E by A ratio. A wave is absent in atrial fibrillation. The challenge in this is the tachycardia. However, you can settle the tachycardia by giving the beta blocker or reassure the patient, and then you measure. This is the way we measure the isovolumic relaxation time, and it is inversely proportional, inversely related to the LV filling pressure. Another criteria is called the color mode propagation velocity. You see, for that we get the apical 4-chamber view. We put the color flow, get the cursor absolutely parallel to the mitral forward flow, and instead of getting the pulse wave Doppler, we are getting M mode. You switch on the M mode button. So what will happen? You will get a picture like this, where you can see the mitral valve here. Look at the whitish linear structure. That is the mitral valve, here also, and the flow pattern. You see, this is the fast wave is the isovolumic, the rapid filling phase is here and followed by late rapid filling phase. So the early rapid filling phase, we take what we do. As I said, this is the mitral valve level. So we measure the slope of this fast wave, starting from the level of the mitral valve and go inside the left ventricle by 4 centimeters. So basically what we are measuring? We are measuring how fast the blood is moving from the base of the ventricle towards the apex, how fast it is moving. So if the elastic recoil is good, myocardial relaxation is good, you get a steep slope. As in this case, it is 163 centimeters per second. Normally, it is more than 50, and in all other grades of diastolic dysfunction, it is reduced, less than 50. And in this case, it's a very good ventricle and good elastic recoil, good relaxation of the myocardium. That is why we are getting a very high velocity. On the other hand, if you look at this patient of hypertrophic cardiomyopathy, look, the atrium or no, this is a cardiac amyloidosis, thick myocardium with biatrial enlargement. Look how slanted the flow propagation of the blood from the base towards the apex. This is the mitral valve level, and we measure it, the slope. We go till 4 centimeters inside the ventricle, and we see that VP is only 29.88 centimeters per second. So this is the way we utilize the color M mode propagation velocity for assessment of diastolic function, though it has got the low feasibility and reproducibility, but a very it helps when we have atrial fibrillation. In atrial fibrillation, it is difficult to measure the LV filling pressure, as I have said. Here, if E by VP is more than 1.4, it indicates raised LV filling pressure. And E by VP more than 2.5 predicts PCWP more than 15 millimeter of mercury in the patients with reduced LV ejection fraction. Now, see, till now, we were measuring everything, all Doppler parameters, when the patient was in resting condition. I mean, patient was lying down on the bed. As I said, the patient who are having the grade 1 diastolic dysfunction should not be supposed to have the shortness of breath, but there is a group of patients when they become symptomatic, especially when they start doing exercise, say walking, they become short of breath. So they go into heart failure. This is the group where we proceed to the diastolic stress test. What is that? As I have said, we were measuring the diastolic parameters at rest. Now we will measure the diastolic parameters with exercise. Because to look at this graph, particular graph, in a normal subject, both at rest and exercise, LV end diastolic pressure remains normal. In advanced heart failure with preserved ejection fraction, at rest also you get a high LVEDP, so also with exercise it rises. But the patients who are in early HFpEF, their LV end diastolic pressure is normal at rest. You are getting a grade 1 diastolic dysfunction. But as they start doing exercise, their LV end diastolic pressure rises and they go into failure. We have to identify that group of patients by doing exercise stress test. Why does that happen? In a normal subject, when you see the LV diastolic function, there is an augmented myocardial relaxation with more powerful early diastolic suction with exercise in a normal subject. That increases the E pressure, the E wave, as well as the E prime. So if both E by E prime increases, that keeps the E by E prime normal. So we get normal LV filling pressure by measuring the ratio. On the other hand, in this particular group of patients who are in early HFpEF, having normal LV filling pressure at rest, and as they do exercise, there is no augmentation of myocardial relaxation. So required cardiac output is achieved at the expense of increased LV filling pressure. So what will happen? Though the E wave will rise, there will be no change in the E prime. There is no change in the E prime. So E becomes tall, E prime is not increasing. So that changes the E by E prime ratio. It gives a high E by E prime ratio, indicating raised LVF, and that is why the patient is having shortness of breath. Now, let me show how do we do it in our lab. What do we do at rest? Step 1, at rest, we get all the diastolic parameters of this particular patient, and then we ask the patient to walk on the treadmill, and the patient is asked to walk till he or she becomes short of breath. So it's a symptom limited exercise. And as soon as he becomes short of breath, patient lies on the bed. And again, I take the diastolic parameters, step 3. So step 1, 2, and 3. Now look at rest. E wave was this much and increased, but look at the E prime. At rest, it was this much, 7 centimeter per second, reduced to 6 centimeter per second at stress. So if you see the E by E prime ratio at rest, it was 9, and it has increased to 17.6 at stress. So a post-exercise E by E prime more than 13 is 90% specific and 60% sensitive for raised LV filling pressure. So these we are getting by asking the patient to walk on the treadmill, and we are getting the diastolic parameters before and after exercise and comparing it. The similar finding can be obtained by at rest, not asking the patient to walk on the belt. You just passively raise the leg of the patient. When you are assessing the diastolic parameters, you are not getting the sign of LV filling pressure, but you are suspecting. So what you do, you elevate the legs passively to about 70 to 80 degree. That will increase the preload, and that will unmask the elevated LV filling pressure, resulting in E by E prime to reach more than 14. The advantage here is that you don't get a very fast heart rate here. So E by A wave remains separated. On the other hand, if during exercise, what happens? The patient becomes tachycardic due to exercise, and there is merging of the E and A wave. So you have to wait for a while till the E and A get separated, so that time you can measure the E wave velocity. There are certain advanced techniques also for assessment of the diastolic dysfunction, like volumetric analysis of the LA by 3D, LA strain, global LV longitudinal strain, longitudinal diastolic strain, and LV untwisting rate. Out of these, the LA strain has gained its popularity because it is said that papers, medical literatures have demonstrated that LA strain is an important biomarker for early HEPPEF patients. It improves the diagnostic accuracy if the LA reservoir strain is high and is low, and prognostic marker also, because lower absolute reservoir LA strain was noted in the patients with a previous hospitalization. This was seen in a prospective comparative study of ARNI with ARB on management of HEPPEF trial. However, this particular criteria is in the advanced stage of research, though it is not yet a routine practice. It is the method of future, so you must know it. And there are machines in our lab, in some of the labs where we are doing it regularly, but we'll have to wait till it comes to the routine practice. So, my dear friends, to conclude, I would say, though it is very one of the most critical part of the echocardiographic examination is the assessment of diastolic dysfunction, but you can do it if you do it carefully and keeping it simple and follow the algorithm as I have said. Thank you.
Thank you very much, Debika, for excellent presentation for the diastolic functions. And now I'll start this as a question answer session. Anybody would like to ask some questions?